Health and Human Services Committee will come to order. Representative Pearson moves approval of minutes from March 7th, 2017. Are there any additions, corrections? Seeing none, all those in favor of adoption of the minutes from March 7th, please say aye. Those opposed, nay. Minutes are adopted. Members, I'm going to start out with House File 1559, which, unless there's any opposition to it, I'd present from here in the interest of time. I will move House File 1559 be re-referred to the General Register. We have the bill before us. I have an A1 amendment, which is an author's amendment. This corrects a cross-reference that's in the bill and deletes a section that DHS has confirmed is not necessary. Oh, I'm sorry, it's the A1-1 amendment. All those in favor of adoption of the A1-1 amendment, please say aye.
Aye.
Opposed, no. The A1-1 is adopted, and 1559 as amended is before us. This deals with MA payment rates and deals with our hospitals. Rather than trying to clumsily walk through this, I would prefer that Ms. Krinke come forward and kind of march through this. There's it has very little overall effect, but it does have some effect on rates, so we would want to walk through that, make sure everybody understands it. And so, Ms. Krinke, if you would come forward, please introduce yourself for the record and just kind of give us a brief walk through the bill, please.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association, representing 143 hospitals and healthcare systems across the state. First of all, we'd like to thank Representative Dean for authoring this bill, as well as the co-authors, Representative Schumacher and Representative Liebling. This bill is taken from the governor's budget book on page 95, and if you want to, you can read this and you can learn an awful lot about hospital rate setting. And these 3 pages of the governor's budget book is about everything you would ever want to know about diagnostic-related groupings and how hospital rates are set. It is pretty technical, and it is good reading, particularly late at night if you're tired.
Members are all writing down the numbers again?
Yes, page 95, page 95.
95.
Yes, and it is called Provider Payment Modernization, and we affectionately refer to it as hospital rebasing. And while this bill is pretty technical in nature, it is very important to both the hospitals and the medical assistance patients that we serve. The hospitals supported moving to what is called a diagnostic-related grouping payment methodology. Prior to this, every single hospital for every single service line had its own payment rate, and DHS had to set this for every single hospital, every single service rate. And a few years ago, we went to what's called a diagnostic-related grouping. It's the same system that Medicare uses, and the system became much more transparent, and it is broader based across the system now rather than every individual hospital. So what happened when we moved to this DRG methodology, it had a tendency to undervalue services that do not use a lot of resources, okay? So services, the DRG methodology puts a higher weight in payment on services that use more resources, and it undervalues services that use less resources. So what happened is when we saw this, we gave the Department of Human Services what was called the authority to have policy adjusters. And we got our members and we talked to the hospitals and we said, okay, what would be policy adjusters that we would like to give to the department so they could move some money around between services? And we identified 8 policy adjusters, and they were mental health, neonate, normal newborn, obstetrics, transplants, trauma, pediatrics, and rehab services, okay? So it was fairly complicated to come up with those 8 service lines. And I would like to just give you 2 examples, Mr. Chairman, and I think that this will make this issue a little bit clearer, if I may. Examples always help. So if we don't pass this legislation this year, inpatient mental health services would be cut in half for their payment rate. And that is because mental health services use more counseling and use more peer-to-peer, and it's physicians advising and working with people, but they don't use a lot of equipment or a lot of technical materials in their care for the patient. So that service is undervalued under this DRG methodology. So we are hopeful that the Department of Human Services, when they get this authority, they will use a policy adjuster to increase the payment rate for mental health, okay? Another policy adjuster that the department supports, and so do we, is to, right now in Minnesota, 40% of all births in our state are paid through the medical assistance program. And right now, the payment to cost ratio is very low for obstetrics, and the department has indicated that they're very worried about access to OB services in some of our rural communities and across our state. So the department is recommending a policy adjuster to bring the payment rates up to at least 50% of the costs for OB services. Now, our MHA board looked at this and they said this is the right thing to do. So we're moving a little money within Medicaid to these key service lines, and we're taking a little money from the other services in order to be able to do that, okay? So we've got an agreement that these are the areas that need a little bit more money, okay? So we have sign off from the MHA members. We think it's the right thing to do. We're supporting the recommended policy adjusters from the Department of Human Services. It is fairly technical, and we would certainly appreciate your consideration for these important service lines within our medical assistance program, Mr. Chairman.
Thank you, Ms. Krinky. And from the way I understand it, that we kind of gave authorization for this, and if we don't do something, we're going to have a cut because it sunsets, and we're going to have a little bit of adjustment in mental health, OB, and the other areas that you cited, but it shouldn't be incredibly controversial on a losing end or on other pieces that might create some issues that we're not hearing about or thinking about yet. Is that correct?
Mr. Chairman, that is a very good summary of the bill. The policy adjuster authority, when we did this a couple years ago, we sunset that authority. So what we're doing is we're reinstating that authority to move this money.
All right, thank you. Representative Murphy.
Thank you, Mr. Chair. And Ms. Krinky, you were talking a little bit about DRGs, and it seems to me we've had those for a little while, right? And I want to just dig in just a little bit further on the question of undervaluing a service, and then what that means for care delivery and for hospital revenue. So for something as important as mental health, that isn't a lot of high-tech bells and whistles, but instead, collaborative counseling, team-based approach, right? But often inside a hospital. When that service is undervalued in terms of the revenue it produces for a hospital, what does that mean then for the provision of care?
Ms. Krinky.
Mr. Chairman, Representative Murphy, we cross-subsidize not only to other payers, like we've heard about with the commercial payers versus government and Medicaid, we also cross-subsidize internally within hospitals. So traditionally, surgical procedures like a knee or hip surgery are generally procedures that hospitals might make a little more margin on, and they tend to subsidize the services within a hospital that might make a little less money. Like mental health is kind of a very typical service line that hospitals traditionally have lost revenues on.
I'll leave it at that, Mr. Chair. Thank you.
Thank you, Representative Murphy. And any other questions from members? All right. Seeing no other questions, anybody from the audience that would like to testify on this bill? All right, seeing none, I'll renew my motion that House File 1559 as amended be re-referred to the General Register. All those in favor, please say aye. Aye. Opposed, no. The motion prevails. 1559 as amended is re-referred. Next up, we have, you want to go to that one? House File 1619, Representative Schumacher. And while Representative Schumacher is making his way around the corner. Today is lobby day for the Commission of Deaf, Blind, and Hard of Hearing, and we welcome all you folks here, and it's great to have a translator here today, so thank you. Great to see you. Appreciate you being here today. Representative Schumacher will move House File 1619 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. Representative Schumacher, you have no amendments that I see in the packets. The bill's before us. Please proceed to your bill.
Thank you, Mr. Chair and members. House File 1619 is the DISH bill that we all should have been made privy to over the last few weeks. As background here, both Gillette and Children's hospitals receive federal disproportionate share hospital payments, and that acronym creates the sound of DISH, which is where we get the name of this, because of the high volume that they have for MA patients. These payments help offset the losses for serving high Medicaid populations. The CMS has implemented a new interpretation of a federal law that required states to include commercial insurance payments for Medicaid-eligible patients in the uncompensated care calculation. This is an interpretation which was discovered first on CMS's website as FAQ number 33. It's not a law change, it's not a rule change, it's just an interpretation change at the federal level. If that interpretation is upheld, these two hospitals face losing more than $25 million a year together. This bill attempts to protect those payments that these hospitals currently receive under our state MA programs if the interpretation is upheld. This isn't new money that's going to the hospitals, it's simply maintaining the state portion if the interpretation stays. And we do have some testifiers here if there are questions from members.
All right, thank you, Representative Schumacher. Are there questions? Representative Murphy.
Thanks, Mr. Chair and Representative Schumacher. Maybe for one of your testifiers, thanks. I'm a supporter of this co-author on the bill, and I know what we're trying to do is anticipate a decision that could come our way and impact the revenue to children's hospitals. I'm also wondering if you have advice for us about the impact of the now announced repeal of the Affordable Care Act and what that does to DISH or to the revenue that would come your way as a result of that. So is there interaction or interplay between this issue and what we've seen now produced in DC with regard to hospital payment?
Representative Schumacher.
I think we'll let the testifier.
Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you. My name is James Haddigan. I am the Chief Financial Officer for Gillette Children's, Specialty Healthcare. And as you know, both Gillette and Children's are participating in supporting this bill. So I believe I can speak for both our interests in that. So to answer your question, we're not sure really what the impact of the new federal legislation on DISH is going to be yet. So we have to, at this point, still proceed with what the current rules are. So in that sense, and I'm not sure I remember, was there more to your question you needed?
Mr. Chair.
Representative Murphy.
And maybe just to follow up, have you, I know the hospital, the National Hospital Association has taken a position on the proposal. And I don't know that through your interest for Gillette or for Children's Hospitals, you've been able to take a look at what they're proposing in terms of disproportionate share. But I'm curious about that part specifically. Not that we know that it's going to happen, but if it did, right now that it's a live proposal, what would happen to the disproportionate share that's coming your way?
Mr. Haddigan.
Yeah, yes, Chair, Representative. Again, my understanding is that the federal proposal will do a per capita, essentially block grant to states, and within that, probably there is decisions that can be made by the states on their DISH. Currently, that's the case. States have a lot of leeway in how they use DISH. That's one of the reasons that Gillette and Children's opposes this rule change or this interpretation of a rule by CMS, because they are stripping the state of Minnesota and other states of that ability. So the short answer, without having read the federal legislation yet, is I think DISH can still possibly play a role, and it traditionally always has played a role for children's hospitals. That's in the original statute at the federal level.
And Mr. Chair, and I have not read the entire proposal, but understand that DISH for expansion states, and we're an expansion state, would be eliminated in Medicaid in 2020. So in just a few short years, then disproportionate share, which is a revenue source, an extra revenue source for hospitals that have a disproportionate share of high-cost cases would be eliminated in Medicaid. And I think we have to, I would like from you, if you don't know now, I would like to know from you what that means for Gillette and for children's hospitals.
Well, that would have very much the same impact we're talking about with this interpretation of a rule. It would take a great deal of income out of all children's hospitals across the nation, not just ours, and would be a real detriment to children's hospitals' ability to continue to give good care to children who are covered by Medicaid.
Thank you.
Other questions? All right, seeing no other questions, do you have additional testifiers?
Only if there are questions, Mr. Chair.
Didn't think so. Okay, any final comments?
No.
Didn't think so. House File 619 is laid over for possible inclusion in the Health and Human Services Omnibus Bill. Next up, we have House File 1758, Representative Liebling. Representative Liebling moves House File 1758 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. We have the bill before us. Representative Liebling. I see no amendments to your bill. Representative Liebling, you have one testifier and your bill.
Thank you, Mr.
Representative
Chair.
Liebling.
And actually, I have another testifier as well who'd like to say a few words. But members, first of all, Mr. Chair, thank you very much for hearing this bill. We've heard a lot about that we are looking at we have kind of an uncertain future in terms of what our funding is going to be for health care and health and human services. And I think it's especially important for us to focus on things that are going to save money down the road. And this is an area where I think the evidence is very clear that by putting some money in at the front end, we can save a lot of money on the back end. So there are approximately 300 new HIV infections every year in Minnesota, new infections. And that is very costly because every new infection it costs around $400,000 for the lifetime cost of dealing with that disease in that one person. So we're talking about $400,000 of publicly funded medical care for the most part. So every year that would add about $120 million in publicly funded medical care. So if we can get ahead of this and head off these infections, this would really save us a lot of resources that we could use in other areas. So the bill is for prevention grants, and it's for $1 million in 2018, $1 million in 2019. That would be for competitive grants to do some things that, as I understand it, there's pretty good evidence-based interventions that can be done that can try to prevent new HIV infections and head off the human cost, but also the fiscal cost. And that's all I'm planning to say. I'm going to turn it over to my testifier and let him give you a brief story about his experience with this issue.
All right, Representative Liebling, welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Thank you, Mr. Chair. My name is Nick Denning. I grew up in Crosby, Minnesota. Growing up there, I was not exposed to anybody living with HIV. I was unaware of any risks or potential transmissions that could take place. After high school, I joined the Army National Guard as a paramedic. I then moved to the cities in 2004. I was introduced to a small group of friends, and in that small group of friends, I had met my first person who was HIV positive. I kind of avoided that individual. I was unaware of how the risk of transmission took place, so I decided avoiding them would be safer than to approach the unknown. So then, on December 13th, 2005, I was diagnosed with HIV at the age of 21. I had reached out to a program at the Minnesota AIDS Project called Positive Link. It is a group that helps people living with HIV, both men and women. It is funded by the Minnesota Department of Health. This program offers a number of supportive services, including support groups, social activities, and one-on-one individual meetings. And the demographic at that time was not what I wanted it to be. I was 21 years old. The main demographic of that program was probably age 50 and above for men who are living with HIV. I avoided going to those social activities due to the fact that there wasn't really any resources for people around my age that I was aware of. After about 3 to 4 years of suffering from severe depression and feeling very alone, I decided it was about time to start medication. Again, I reached out to the Positive Link program, met with the current coordinator, or the coordinator there, and he had told me about the number of things that I can anticipate while going to the doctor to get set up with meds. Talking to him really kind of changed a lot of my perspectives. I started learning more about the disease and how it's transmitted. And in doing so, I became pretty active with the Minnesota AIDS Project. Currently, I am now the coordinator of that program myself. I meet with a fraction of the people who are diagnosed with HIV on a daily basis. Unfortunately, there are a number of people who are still left out in the community who are not being reached, especially communities who are very underserved. So this bill would definitely allow for more testing, outreach, and education to specifically those underserved communities. Thank you for your time.
Thank you. And we have another testifier. Welcome to the committee. Please introduce yourself and proceed.
Chair and committee, my name is Matt Tobier, I'm the Public Policy Director at the Minnesota AIDS Project. And as Benjamin Franklin said, an ounce of prevention is worth a pound of care, and that's really what this bill is about at the end of the day. Given the dramatic progress in HIV/AIDS prevention and care, Minnesota has the exciting opportunity to achieve an end to AIDS. While advances in antiretroviral treatment have dramatically improved the quality and length of life for people living with HIV, similar gains have yet not been achieved in HIV prevention. However, with proven prevention strategies for HIV-negative people at high risk for infection and targeted interventions with HIV-positive individuals who are out of care, we now have the necessary tools to stop and ultimately reverse the epidemic. Inadequate state funding and recent reductions in federal funding for HIV prevention threaten the significant gains Minnesota has made in fighting this epidemic. Minnesota's state funding for HIV prevention has been flat since 1998. In addition, Minnesota has lost over 40% of federal prevention funding in the last 5 years, significantly impacting our ability to combat new infections. Increased prevention resources for targeted, high-impact interventions can be used to quickly test, diagnose, and link into medical care the estimated 1,100 people in Minnesota who are HIV positive and unaware of their status. In addition, funding is needed for increased interventions with the 40% of all Minnesotans living with HIV who are currently not in treatment to find and link them into care and medications. Increasing activities in these two areas will lead to a significant reduction in new infections. We have the know-how, tools, and ability to close these gaps. What we lack are the resources. By investing in HIV prevention, we can save taxpayers money, we can save lives, decrease new infections, and we can reduce health disparities that are unacceptable and unjust. With increased prevention, we can continue the vital progress to eliminate HIV in Minnesota. Together, we can once and for all end AIDS. Thank you for your time and for your support for 1758.
All right, thank you for your testimony, Mr. Tuberin. Are there questions? Representative Murphy.
Thank you, Mr. Chair. Mr. Toberon, thank you for your testimony. $1 million in each fiscal year is a big round number, nice round number, and I am curious to know if you believe that this is an adequate amount of funding, if this is the amount of funding that could actually get us to the goal that you're describing, which is to end AIDS infections here in Minnesota.
Mr. Tuberin.
Mr. Chair, this is a start. This would get us on the path. It certainly wouldn't get us all the way.
And Mr. Chair,
Representative Murphy.
thank you very much. If you were able to write that number, what would it look like? And if you don't know, it's okay.
I-
I'm really trying, it is, when there's a condition like this that is preventable with early intervention, it's good for humans, and it's good for our healthcare delivery system, and it's good for our healthcare budget. And I don't know to the scale that you're describing. So if you don't know, it's okay, and I understand, we're in a budget hearing. But I am curious to know what it would take for us if we wanted to really reach that goal. What would it take for us to invest to get there?
And Mr. Chair and committee, there are a number of national estimates that we could use to sort of get to that number. And there is a national HIV/AIDS strategy that lays out goals on how we can get to that path. For those of you on the policy committee tomorrow, you'll be hearing a bill that we're working with in collaboration with the Department of Health in order to develop a strategic plan to specifically hit those goals and to come back to the legislature with specific policy and funding recommendations to reach exactly the goals that you're talking about.
Thank you, Mr. Chair. Thank you.
Thank you. Other questions? Is there anyone from the audience who'd like to testify on this bill? Final thoughts, Representative Liebling.
I know that HIV isn't always the most popular cause, but I think that there are a few things that we actually can do to save costs in our system. And there are things that we can be doing in this area. And now is the time, because we want to be able to, in the future, have our obviously we all know that we're going to need resources for people who are elderly, for people with disabilities, and if we can intervene at the front end of some of these conditions and really make a difference, I think that is a really good use of our funds. So thank you, Mr. Chair.
Thank you, Representative Liebling, and thank you to the testifiers for coming and presenting us with your testimony today. We do appreciate it. With that, House File 1758 is laid over for possible inclusion in the Health and Human Services bill, omnibus bill. Next up, we have 1784, Representative Kresha. I will move that House File 1784 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. There is a DE1 amendment. I will at this time move the DE1 amendment. Representative Kresha to the DE1 amendment.
Thank you, Mr. Chair, and that just gets the bill in the shape that I'd like.
All right. Are there questions for the DE1 amendment? Seeing none, all those in favor of adoption of the DE1 amendment, please say aye. Those opposed, no. The DE1 as amended. Representative Kresha to House File 1784 as amended.
Thank you, Mr. Chair and members. And with the amendment on, we just add clarity about who's eligible to apply for funds and what's expected. Target home visiting is a proven strategy for supporting at-risk families and children to get the best start possible. I understand this is a big ask. I understand in a budget cycle that there's a lot we're trying to accomplish here, but this is one of the bills that seems to have an impact. Families receiving targeted home visiting have access to information and support services to improve the health and well-being of children and families, support for improved readiness for learning in school, and support for maternal outcomes, including education, workforce participation, and health. Mr. Chair, members, I hope you'll support this bill as amended, and I'd like to ask a couple representatives to speak on behalf of the bill.
Thank you, Representative Kresha. Please introduce yourself for the record and proceed in whatever order you would like.
Mr. Chair, members of the committee, my name is Laura LaCroix DeLune, and I'm the coordinator of the Minnesota Targeted Home Visiting Coalition. We represent nonprofit organizations, local public health and tribal health organizations that provide targeted home visiting services to families across the state. And each year, nearly 12,000 children are born into poverty in Minnesota, and an additional 4,300 children are born to families facing extremely difficult situations such as homelessness, incarceration, violence in the home, or mental health issues. And we estimate that about 7,700 families who are eligible to receive services do not due to resources. So providing additional support to these high-need families is a goal of ours because we believe it has impact in either 2 or 3 generations for Minnesotans. So as amended, this bill would allow communities to make decisions locally about decisions on how nonprofits, local public health and/or tribal health organizations could work collaboratively together to address these high needs, which is a new way of operating with these types of funds. We've asked Leslie Buchenville to join us so she could actually speak directly to the targeted home visiting work that they do in their family centers.
Welcome to the committee. Please introduce yourself and proceed.
My name is Leslie Bouchonville. Mr. Chair, members of the committee. I am the executive director of 2 family centers in northern Minnesota in Cass County, the Pine River Bacchus Family Center and the Northland Family Center. And we really know what collaboration is. We work together. We developed a home visiting program and have been doing it with pretty much from the nonprofit status. I mean, asking foundations and locally asking money to support our family center. The reason that we are here today is to talk about the home visiting program and the high needs, the families that we see in our area with high needs and what this program can do for them. Our mission is to strengthen families and build a strong community, and we do that collaboratively. We work together with any entity, public health, the county. We work with our local organizations, and when you have 14 persons per square mile and poverty rates with free and reduced lunches from 45 to 75%, there's definitely a need. I did bring along some materials that Laura has that you can look at while I continue to speak to a story. So I'll just. A young couple who were first-time parents felt they were trapped in a hopeless and scary situation. They felt they were being controlled and played like puppets. Home Visiting and the Alternative Learning Center worked together to show this couple that they were indeed in control of their own lives and help them work out a plan to get where they needed to be. They worked very quickly and effectively and accomplished all of their goals, including graduation. And now they are safely out of the situation and thriving on their own, far from the reach of the perceived oppressor. We have many different families that come into the program. Sometimes we have very young moms that we work, and the relationship that we create with them is what allows us to work with them and their children. Right now you're seeing some of the curriculum that we use. We use a curriculum called Growing Great Kids. This gentleman here is holding brains, so we talk about brain development, and we actually have the parent create a brain, and we talk about how that is so important to talk to your child and to attach to your child. And the heavier brain is the healthy brain, the developed brain. The littler brain is one that has not had the interactions in the language.
And I need those back at the end of committee.
We believe.
So the Pine River Bacchus and Northland Family Center support House File 1784 because one of our primary barriers to expanding home visiting in greater Minnesota is access to sustained funding. Sustained funding is critical as we make multi-year commitments to families. Part of what we do is create a relationship. It's really hard to know if we can stay in that relationship. We enter prenatally until 3 years old. That's a commitment we make with the family. It's really hard to do that and we're also using our resources to find dollars. So our targeted home visiting programs are very successful, and like many community-led programs, fill gaps in our communities and employ a highly diverse workforce to meet specific community needs. Many targeted home visiting programs employ social workers, parent educators, as well as paraprofessionals. The home visiting workforce is often diverse and reflects the populations we serve. We believe this new funding source could provide critical resources to organizations such as ours across Minnesota. We ask for your support. Thank you.
Mr. Gehrman.
Welcome to the committee. If you could just state your name for the record, and we look forward to your testimony.
Thank you, Mr. Chair, members of the committee. I'm Rich Garriman. I am the Executive Director of Safe Passage for Children of Minnesota. We are an advocacy group, a citizen advocacy group in the child protection and foster care arena. I was also a member of the Governor's Task Force on Child Protection. We support this bill because we do our own research in this area, and targeted home visiting programs are among the most effective in terms of actually reducing the rate of child abuse and neglect. They're a preventive program in that respect. As many of you know, as a result of the Governor's Task Force, counties are now following the same guidelines in terms of screening in reports of maltreatment. And so we understand from counties that caseloads are growing significantly. So targeted home visiting programs can have the impact of reducing or moderating that caseload growth by legitimately reducing the number of families and children who end up in child protection and foster care. So that's a tremendous benefit, moderating those caseloads, and we also think it'll have a direct positive impact on reducing racial disparities in child protection and foster care. So we want to lend our support as well.
And we have one further no? Is there anyone from the audience that wishes to speak to the bill before us? Members, any questions for the author or for the testifiers? Representative Krisha, you have the final word.
Thank you, Mr. Chair, members. I guess I would just close quickly with, through all the work that I've done in the child protection, the foster care, early ed, the one thing that keeps coming back to me is that many of these families, they don't define their normal the same way that many of us have that same experience. When I grew up, my normal was very fortunate. I could refer to my parents when I had problems. My son calls me now on things, even though he's 22 and the other side of the world, and my daughter in college can call me. There are many families that don't have that, and that normal doesn't exist for them. So this is a way that, and I've seen this time after time again when I work with many families in need. If they just had somebody who could give them those bumpers, set the rails of life up a little bit for them, it'll get them heading in the right direction. It's an awesome bill. Just pass it.
Thank you, Representative. With that, House File 1784, as amended, is laid over for possible inclusion in the Health and Human Services Omnibus Bill. Thank you, Representative Krisha, as well as your testifiers. Thank you for your testimony.
Looks like the background's
Oh, yeah. Oh, we do need the curriculum back in my brains.
You're in debate.
Representative Keel, welcome to the committee. I move House File 952 to be re-referred to the General Register. Representative Keel, we have the bill before us. So to your bill.
Thank you, Mr. Chair, members. House File 952 is in regards to addresses most of our visitors today. I'm sure that every one of us in this room knows someone with an age-related hearing loss. Most of us have someone in our family with it. This isn't surprising because 2/3 of the people over the age of 70 have hearing loss to an extent that it impedes their ability to concentrate and communicate. Recent research says that age-related hearing loss is important. Those with mild age-related hearing loss are 2 times more likely to develop dementia. Those with severe age-related hearing loss are 5 times more likely to develop dementia. This bill is about ensuring that people who care for and work with seniors know about age-related hearing loss. Originally, the bill was to have required 2 hours of training for staff in assisted living facilities for those who have age-related hearing loss. But there were some concerns about the facilities and the requirements in the proposal, so we removed that. And this ensures that high-quality training on this topic counts toward training requirements established by law. Gives people a little bit more of a ability to understand what it is they need to do when someone has trouble hearing. It's a small step, but an important one that to ensure people that are caring for seniors know how best to communicate with them. So today I have with me Kathleen Marin, and she is going to testify to House File 952.
Ms. Marin, welcome to the committee. Please state your name for the record, and we look forward to your comments.
My name is Dr. Kathleen Marin. I'm a psychologist with a significant hearing loss. Today, however, I'm here in my capacity as the daughter of a woman who has been in assisted living, memory care, and is currently recovering in a nursing home from a fall. I go and visit her almost every day. I know the staff. I know how things work in these 3 places that she's been. First of all, I want to say how grateful I am that we have such dedicated and caring staff. I'm lucky that I can trust my mom's care to them. That being said, they are not trained in hearing loss. And because of that, no matter how much they want to help the residents, they're often doing things that are unhelpful or even hindering what's going on with the people who live there. And I want to just give you a few examples coming from each of the places that my mom has lived. And these are places that I like, that we picked for her. In her first assisted living, all announcements for food, mealtime activities were done over a PA system. Every room was equipped with a speaker. It sounds so efficient and so effective, except about half the people there couldn't hear what was being said. And so my friend, who was also in this place, was consistently late to her meals or missed them because she didn't hear the announcements. In my mom's memory care, they get all the residents together to watch the Lawrence Welk Show and other really fun TV shows. Except again, half the people can't hear it. But the people who work there don't know that because they can hear very well. I can't. I sit with my mom and I know that I have no idea what's being said on the TV. Without captioning or an assistive listening device, TV is useless for me. In that same building, they have assisted living and independent living, and they have a beautiful movie theater. No assistive listening devices and no captioning. So again, a lot of the residents can't make use of it. I was with my mom and the aide was helping her get dressed and was just chatting to her and, really keeping her occupied. And then the aide turned and went into the closet to look for some clothes for my mom and continued talking. Well, as soon as she was facing away and then into the closet, I couldn't hear a word, which means any of the residents with hearing loss couldn't hear anything. Another time I was there and the physical therapist was working with my mom. Again, wonderful, very efficient, but kept looking down at my mom's ankle, which is what she was working on, when she was asking questions. So I couldn't hear. That meant the resident couldn't hear. Finally, a lot of times the staff check on the residents from their doorway instead of coming all the way into the room. And a person with a hearing loss cannot hear what's being said when the staff is at the door. And these are just a few examples from places that are good. These are places that we're paying a goodly amount for my mom, and we like them. And then I want to just tell you what it's like for me, person with a hearing loss. It is exhausting to have a hearing loss. I know that there are some of you in here who have a hearing loss, and you know how challenging it is. It's exhausting for me, and I advocate for myself. And here's a good example. I had a doctor's appointment last week. The first thing that happened, I'm checking in. The receptionist is not looking at me. She's looking at the computer. So I couldn't hear what she was saying. Then when the nurse came to pick me up, she's walking ahead of me and talking. I can't hear anything. So when I ask her to please look at me, I tell her I have a hearing loss, she stops talking to me and starts pointing to what I need to do, like step on the scale. She's pointing at the scale, pointing at the blood pressure cuff. Of course, I had to let her know I can hear. I just have to have you look at me. The phlebotomist who was taking my blood draw talked a mile a minute, and I don't know what he said. it's not just in nursing homes. We encounter it every day, those of us with hearing loss. I'm very willing to stand up for myself, but most people don't do that. And so I just think we need to advocate for our vulnerable loved ones in these assisted living and memory care, because they're not of the generation to say, excuse me, can you repeat that? Or to go and research everything about their hearing loss. So I'm just asking you to support this bill to provide training for the staff who work with the people that we love. Thank you.
Dr. Marin, I have a question. When you speak of hearing loss, and obviously every person has a different degree of hearing loss, but could you give the committee some appreciation for gradients of hearing loss in terms of loss on one ear or total, or is there any way for us to appreciate what variance there is in terms of hearing loss? Is there any way to put that in tangible terms?
I'll do my best. That's a big question. For me, I am functionally deaf on one side and what they call moderately to severely deaf on the other. I'm profoundly deaf on this side, but that really means functionally deaf. And that's not necessarily the norm, but that's what I have. When people have mild to moderate hearing loss, they can hear us talking, but probably only understand 75–80% of what's said and guess at the rest. Sometimes we guess right, sometimes we don't. I've made some horrendous mistakes. Once it gets to moderate, to severe, to profound, it actually makes it very difficult to do activities of daily living. And I don't mean getting dressed, I mean sitting at a table and conversing with people. Like when I go to my mom's assisted living, I cannot hear the other people at the table. When you were talking to me, I got part of what you said, and I was doing some speech reading to get the rest. That's lip reading, but it's now called speech reading. There's this huge range, and I think one of the hardest things is that I would say at least half, if not the majority of people in assisted living have not been diagnosed. They don't know they have it, or if they do, they have not been treated. And so I think part of the training is to help the staff recognize the hearing loss, and then maybe we can get something done, and they can get hearing aids, assistive listening devices, captioning, whatever. But I have to say that once you hit the moderate, without those, it's really hard to participate in activities.
Thank you. That was helpful. Representative Keel.
I'd just like to add, too, my mother's hearing is quite a bit like Dr. Marlin's is, and I've watched her walk into traffic because she thinks it is coming from one side when in fact the noise is coming, she can't tell where it's coming from. And so you have to sometimes physically grab her to be able to stop her from walking into a car that's moving. And they think that she's, there's people stopped, because I'll stop and then she'll keep walking, and she gets pretty fast sometimes when she's fearful about what she thinks is coming or where she should move to. So that is a huge identifier for a problem with hard of hearing. And the other thing, I don't know if we talked about it, but isolation. Isolation is huge. When it's too much work to listen, people become isolated, which does not help their mental health at all. My mom and I have that conversation quite often because she says it's just too difficult to talk, so she'll go off and do something by herself.
I have to agree with that. I work to stay in the community, and it is work. And there are days that, like after today, I will go home and I will want no noise, and I don't want anyone to talk to me because I have gotten what they call listener fatigue, where I have truly spent all day trying to hear, and now it's time to just take care of me and to use my term, I veg out. But basically, I don't want to work, and it's work.
Dr. Marin, I just have a follow-up to the concern in terms of you speak to the isolation. And I'm just wondering in terms of people that are suffering from hearing loss, what percentage of people that suffer from hearing loss also suffer from depression, either clinical or otherwise?
I honestly don't know the number. I do know that there is a clear causal link between hearing loss and depression and hearing loss and dementia. And we know that people who have hearing loss are more likely to become depressed and more likely to get dementia. I think that's a great question. I would like to go look up that answer. I honestly don't know it.
Thank you. Is there anyone in the audience that would like to testify to this bill? Seeing none, member questions for the testifier or the author? Representative Lunan.
Thank you, Mr. Chairman. I actually suffer from hearing loss myself, and the things you say are exactly right how you manage. I'm very careful, if I can, in a vehicle, sit in the front seat so people are talking towards me. If somebody's facing away from me and speaking, I don't know what they're saying. And in a group setting, if it's like a classroom where we're all facing the same way, I get to the front, almost to a point of obnoxiousness. I get to the front so people are talking towards me instead of away from me. And you're right, it does get kind of tiring trying to guess what they said and you take a shot at it, and sometimes they're like, I don't even know why you answered that way. I said, I didn't really hear you. You're kind of hard to hear.
Representative, I'll work on it. Representative Pinto.
Thank you, Mr. Chair. Just want to ask, it seems like there are some fiscal consequences to not having this training. I mean, just in terms of delayed care, and it seems like it really would be a real benefit, just even if you just look at the finances. And I guess if the testifier could comment on that, I'd appreciate it.
Me or you? Yeah.
Dr. Marin.
Okay. I think this is an incredibly cost-effective bill. The small amount of outlay to help train the staff is really going to help prevent falls with the huge consequences, financial and personal, to that. If we can delay dementia by even a year, it saves thousands of dollars per person. Certainly, if we can keep people from getting isolated and then they don't develop depression, not only do we save the money for the medication for those people, therapy if they're willing, but they get a real life. And I just think a real life, a satisfying, purposeful life, even in the last years of life, is so important. And this little bit of training can go a long way to make that happen.
Follow up, Dr.
No, thank you, Mr. Chair. Thank you.
Representative Keel, you have the final word.
Yes, Mr. Chair, where is this bill going again?
This is going to be re-referred to the general register.
Okay. I really appreciate that, members. That I think it's a real important conversation. I hope in the future we invest more in it. I think we as listeners and talking to people in general need to make sure that we are careful, that someone hears us, we're looking at them, and speaking clearly and slowly, sometimes just knowing which part of our register to use. I used to have a minister that he was a great speaker, but he would drop his voice at the end of every sentence, and I would miss it. And I don't think sometimes we realize when we're speaking what effect we're having on people. So it's something in general that we should make sure that we're hearing and observing of people. But more importantly, the idea is to help people be successful in their lives, wherever that might be. And I would thank you very much if you would support this bill.
Thank you, Representative Keel. I'll renew my motion that House File 952 be re-referred to the General Register. All those in favor say aye.
Aye.
All opposed, no. Motions prevail, and House File 952 is re-referred to the General Register.
Thank you, members.
All right, Representative Pearson moves House File 774 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. We have the bill before us. I understand that there's an A2 amendment, the author's amendment. We will take up the A2 amendment first. Let's put that on first. All those in favor of the A2 amendment, please say aye.
Aye.
Those opposed, no. The A2 amendment is adopted. Representative Pearson, to your bill as amended.
Thank you, Mr. Chair. House File 774, excuse me, is addressing basically a follow-up to work that we did in 2015 in the legislature to address the issues of the deaf and hard of hearing, and deaf-blind. 20% of the state has hearing loss, and as we heard in previous testimony, it's a huge impact on quality of life, and remains an issue for many of the folks in the state of Minnesota, and we're woefully behind in addressing the issues that they face. So after this bill works after 36 years of improving and catching up with technologies, and also implementation of important federal laws like the Americans with Disabilities Act, and helping with the Individuals with Disabilities Education Act as well. So this bill reflects some of the recommendations of the studies that we did 2 years ago, and provides a plan for the future. And we have a couple testifiers here that can share more specifically how it impacts their lives.
All right, Representative Pearson, I see a list of several testifiers. Why don't we just take them in whatever order you'd like and have the testifiers introduce themselves.
Hi, my name is Jamie Taylor, and I am a member of the Commission of Deaf, Blind, and Hard of Hearing Minnesotans. As a person who is deaf-blind, I wouldn't be here today if it weren't for the services of the Deaf and Hard of Hearing Services Division. Deaf-blindness results in isolation and disconnection from the world without support. Helen Keller made great contributions because she obtained visual and auditory information through Annie Sullivan, what we deaf-blind people call support services providers today, or SSPs. The other thing, they truly make a difference because Deaf and Hard of Hearing Service Division provides these services. The other thing that breaks down barriers is fairly new. It is called ProTactile. It is the person behind me. She is doing, that's what she's doing, giving me tactile information about what is going on in the room, how you are reacting to me testifying. Because of her, I can tell that some of you are nodding your heads and giving me, and going to school. I didn't have that kind of information. I didn't know what was going on. I didn't know that some of you, or some of my friends, were smiling during presentations. That is an open void. If you can imagine not knowing if someone's nodding their head and falling asleep to what you're presenting, it is amazingly awkward. This bill supports services such as training in Protactile and also SSP services. Please support House File 744. Thank you.
Thank you, Ms. Taylor, for your testimony.
Hello, my name is Emily Smith Lundberg, and I'm from Lake Shore, that's near Brainerd. And I'm with the Commission of Deaf, Deafblind, and Hard of Hearing Minnesotans. And thank you, Mr. Chair, for hearing this bill today, and also Representative Pearson for authoring it. 40 years ago, a group of visionary deaf, deafblind, and hard of hearing Minnesotans advocated for legislation that would overcome communication barriers. The legislature agreed, and the Deaf and Hard of Hearing Services Division was created, with regional offices and citizen advisory committees throughout the state. They provide direct consumer assistance in American Sign Language and English, and assistive technology demonstrations, trainings, and consultation, mental health services, and grants that increase access. For myself, as a person who was born deaf, my parents didn't know what to do with me. They were hearing, not deaf. So at the Regents Hospital, where I was born, they suggested my parents go to the St. Paul office of the Deaf and Hard of Hearing Services Division. It was fairly close to the hospital, so they went over there, and they did meet with some of the deaf adults there, and they saw what deaf people look like as adults. And they did keep in contact with them at the Deaf and Hard of Hearing Services Division throughout the years. And they helped my parents in limitless ways as I was growing up so that I could become a confident, competent adult. They helped to make sure that hospitals and clinics in the Brainerd area get interpreters for services. They make sure that they understand what the laws are and that they are responsible for getting interpreter services. They also help audiologists on staff, and they help them to provide more assistive and more questions. They provide role models for me as I was growing up, and as for several of the people who are actually here today also. So they also have provided information for the individual education plans and have been involved while I was in school so that my parents would know what to ask for at the school so that I could get an equal education just like the other hearing students. They also got in touch, helped us get in touch with PACER, which is a parent advocacy group. And they also, the Deaf and Hard of Hearing Services, helped us by loaning my parents equipment, because at a long time ago, there was a different captioning machine you had to get to put on your TV, and so they lent us that. Also, long ago, we used to have a different machine to use the phone called a TTY. So they lent us that so that I had much more access to information. They also provided interpreter referral services, and they helped to make sure if you needed legal services or consultation about services, they provided that. And so it was a wonderful thing to connect people to the world through deaf educators. So that's just a brief list of some of the things that the Deaf and Hard of Hearing Services did for me and my family. So naturally, many things have changed over the past 40 years. And our board has recently heard from regional members and advocates about the services that are needed today and how they need to be modernized. Just 2 years ago, the legislature required a study of how to modernize the division and ensure that all Minnesotans are served. There are over 20 different focus groups throughout the state and hundreds of people who participated throughout the regions, as well as gave input in other ways. They were asked what they needed to have services in their local communities to provide access. And we spent a year working with the various groups and with the commission members to come up with a path forward, and this bill reflects that path. This bill keeps the regional offices and adds virtual and actual satellite offices so that people can receive services closer to home. Ideally, those offices would be co-located with public entities or nonprofits who serve our community. We want the division to educate and train other state, regional, and local service providers about how to work with deaf, deafblind, and hard of hearing people to prevent problems before they occur. This bill will provide a plan for modernizing the services and gives funds to ensure that critical needs are met and that waiting lists do not happen again. So this investment in technology and in staff training will provide services that can be used on a 21st century model. So please support House File 774.
Thank you for your testimony, Ms. Smith-Lundborg. And Representative Pearson, another testifier. Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair and members. Thank you for the opportunity to be here today. My name is Jamie Munson. I am the Senior Manager of Clinical Mental Health Services for Volunteers of America Mental Health Clinic. We recently renamed VONA Center for Mental Health. I've been a clinician serving the deaf, deafblind, and hard of hearing communities for the past 17 years. And for more than 120 years, VOA, Volunteers of America, has helped people throughout our state to gain self-reliance, dignity, and hope. I'm here today to urge you to support this legislation and bring access to our services and to those from similar organizations directly to people, especially those people who are deaf, deafblind, and hard of hearing, more conveniently and more effectively. Our team at VOA has had the good fortune to serve the deaf, deafblind, and hard of hearing communities by providing mental health therapy services in schools, homes, communities, and clinics for more than 12 years. Most of those years supported by grant funding through the Deaf and Hard of Hearing Services Division of the Minnesota Department of Human Services. We served 99 youth in 2016, supported by this funding, and without it, many children, teenagers, and families with serious mental health concerns would have gone without those services and support. As a service provider, I sincerely thank those who have gone before me to advocate for this funding, and I most sincerely thank you and your predecessors for supporting the funding. Today, I'd like to briefly share with you a few successes that have occurred because of this funding for these necessary services. In the fall of 2015, VOA had the opportunity to expand our services to a new region of the state, one great success. Through a needs assessment, we determined that we would expand to the southeastern Minnesota region, specifically setting our sights on Rochester, and then expanding to communities throughout the region. According to a report in 2014 published by the Minnesota Department of Education, throughout the state's 11 regions, there are 2,086 deaf and hard of hearing students enrolled in kindergarten through 12th grades across the state. Of these students, 1,382 live in regions 5, 7, and 11. And that's kind of the central regions of the state. And these areas are served by us at VOA prior to 2015. The grant funding we received in 2015 allowed expansion into the regions 9 and 10, which have 388 students. This means that 85% of the deaf and hard of hearing students in the state of Minnesota now have access to in-person services by our agency. Regions 1, 2, and 3 are also now served by Therapeutic Services Agency, or TSA, also supported by similar grant funding, whose work we fully support and with whom we regularly collaborate. The remaining regions, 4, 6, and 8, are served by telemedicine, and in the future I hope to see covered by in-person services. To meet the unique needs of the Southeast Minnesota community, we spent several months finding the right candidate to fill the position of therapist in that region. We have a full-time therapist in place who is a hard of hearing woman fluent in American Sign Language. Yet another great success. These skills are really important for serving the region because many of the youth in the region use both American Sign Language and spoken English to communicate most effectively. Our therapists can meet the communication needs of all of those clients with a hearing loss in the regions. The therapist serving the Southeast Minnesota region recently shared with me an experience that highlights the needs for this specialty. She attended a school meeting for a student who's hard of hearing. This young man, a teenager, was adamantly against the idea of mental health counseling, despite the need and encouragement of his parents and teachers. He's struggling with depression, isolation, and poor school performance. Throughout the meeting, he was resistant, irritable, refusing to engage in services. Toward the end of the meeting, the therapist took a few moments to engage him directly. She asked him to look up at her. And when he did, she indicated her own hearing aids. And she asked him if he had ever worked with a hard of hearing adult, someone like him. He looked at her, considering, and said he hadn't. She invited him to consider whether it might be different to talk with someone who might truly understand his experiences. He considered it and agreed to meet with her for regular counseling sessions. A huge success. So this young man is just one example of the reason why this funding is so critical for bringing services to communities across the state of Minnesota. Providing services in a person's first language or directly from a person more like the client than different is critical in their therapeutic growth and success. As a result of our expansion this year, we hope to serve at least 110 deaf, blind, and hard of hearing youth throughout our service areas. As a lifelong Minnesotan, I'm proud of our deaf, blind, and hard of hearing community and would like to see it continue to prosper and grow. We have an incredible system in Minnesota compared to many other states for serving this niche community's mental health needs. I sincerely hope you will decide to support the funding requested within this legislation, and thank you for the time to be here today.
Thank you, Ms. Munson. I think we have a couple of other testifiers on the list. I have Sunny Wazalowski and Michelle Paulson.
Actually,
I'm
one
sorry.
before.
Oh, Ms. Gold, sorry. We got you. Welcome to the committee, Ms. Gold. Please introduce yourself and proceed with your testimony.
Sure.
Hello, Mr. Chair. Members of the committee, thank you for giving me this opportunity to talk about something that is so important to me, deafblindness. My name is Emily Gold. I live in Minneapolis with my husband and 4 children, and my 5-year-old Lizzie is deafblind. She was diagnosed at birth with Pallister-Killian syndrome, and there are fewer than 300 diagnosed cases around the world, and it is devastating. When she was born, doctors told us that she had 2 months to live. We should take her home, do the best we could to make her comfortable. They told us she would never walk, she would never talk, or be able to care for herself. She would be able to eat with the help of a feeding tube. Her brain scan showed marked abnormalities and that she was deaf and blind. As you can imagine, I didn't take the news very well. It was a time of horrible grief for our family as we watched the dreams that we had for our daughter disintegrate. No college, no career, no romantic partner to support her into old age, no independence. Of all the things that the doctor said, and of all the dreams that died that day, the most difficult thing for me to deal with was her deafblindness. I was terrified that she would spend her time on earth never knowing me or how much I loved her, that I would never be able to reach her, to know her, and that she would live her whole life trapped in her body, in a dark and silent world alone. I had no idea where to start. How could I communicate with a child that couldn't see or hear me? We were referred by her geneticist to the Deafblind Project of Minnesota, and a woman named Sally Prouty called me. She told me that the project could help us reach Lizzie. My only frame of reference for deafblindness was Helen Keller. So I told her, no, you have made a mistake. My daughter is not Helen Keller. You cannot help her. We don't belong there. She explained to me that deafblindness is not just Helen Keller, that every person with deafblindness was absolutely unique. There's no one size fits all, and that Lizzie did indeed belong. I took every parent training the Deafblind Project offered, and Lizzie started working with a trained intervener at the age of 1. The results were amazing. I got to meet and know my daughter. Her intervener was able to open the world to her and to teach me to communicate. Lizzie's almost 6. She's in kindergarten, And with the help of her home and school interveners, she is learning, she is growing, she is communicating. She has almost 20 signs. She has a best friend at school that she does everything with. She laughs, she plays, she lives. She interacts with her family and the world, and none of this would have been possible without deafblind services. The work that is done to support deafblind children, individuals, and families is not just necessary, it is transformative. It is awe-inspiring, and it gives hope to parents like me who watch their dreams for their children disappear on diagnosis day. Understanding deafblindness and receiving support from trained interveners has allowed me to dream again. The dreams I have for her are different now, but I have hope. Hope for a full life with meaningful communications and relationships. When interveners look at my daughter, they don't see a child who wasn't supposed to survive. They see a child in need of the tools to thrive. I urge you to support this bill and put these tools in the hands of children, individuals, and families who so desperately need them. Thank you.
Thank you, Ms. Golden. Representative Loeffler.
Thank you, Mr. Chair, and Ms. Gold, thank you so much for sharing your story. And I remember being shocked when I was sitting in this room and learned that we had a waiting list for deafblind children getting services. And I'm wondering if the delay to your getting an intervener and a help until Lizzie was 1 was due to that waiting list, and do we know if that waiting list still exists?
I know that there are not enough trained interveners for the population, and I know that we had to wait until there was an intervener available. So it is due to the fact that there are just not enough interveners for the number of deafblind children and individuals. So that gap in her learning is preventable.
Thank you, Mr. Chair. And I know we've heard a lot of scholarship program and loan forgiveness programs for various health professionals, and I think this was one that we need to step up. I can't imagine what it's like trying as a new parent to figure out how to relate and build a supportive relationship with a new infant and not having that coaching from day one about how to help that child interact with the world and with yourself and their siblings, and to get off to a good start. We know how much of the brain development happens in that first year, and to wait a year is a long time. So thank you for sharing that and for the good outcomes that Lizzie's having.
Do you have further testifiers?
Is Jamie Munson, I think, is our next?
No, she's...
oh, I'm sorry. Thank you.
Michelle Paulson or Sunny Wazalowski.
Sunny's ready.
Sure.
You'd like me to sit across from you?
Okay, no problem.
Hello, Representative Dean, members of the committee. Thank you. I'm going to sign my testimony today and have my interpreter speak for me. My name is Sunny Wazlowski. I'm from Faribault, Minnesota. And I came here as an individual, as well as someone who's well-connected, a member of different organizations within the deaf community. My comments that I shared with Brian Daniels is my representative in Faribault. His son is deaf, and I love this guy. He's been such a great advocate for us. I'm sorry he's not here today. He was asked to support this bill, and the bill is great. It's a good bill. However, there's, as Brian and I have discussed it, there's a couple things that in talking with the deaf community in Faribault, that we had a town hall meeting, in fact, about it, and had several people come. You know, we have town hall meetings several times a year to talk about different issues facing our community, and he talked about this. He's kind enough to open his home to have us in his home to have these meetings. So when we looked over this bill, there were some details that I had to take issue with, and Brian's giving me some homework to read through the bill. He said, go through, review it, let me know what kind of changes you have and what else we can do to improve the bill. So I really appreciate his openness. If not for Brian, I think some errors would be getting through in this bill. I'm not sure who really coordinates the the committee hearing, but thank you for allowing me to testify today. I'd like to testify, I'm not really opposed to the bill. I think that's a misnomer to call me someone opposed to the bill. But if I could clarify, I do want to share some concerns that I have, some vetting that needs to go on with some of the comments in the bill, some of the provisions of the bill. Concerns I have shared with Brian, I'm sorry I keep calling him his first name, I should say Representative Daniels. But when Representative Daniels and I spoke about some of the statistics in the bill, we thought that there were some old numbers. And now I know this has been revised, and so some of my comments to sections and provisions don't line up with the new way the bill has been written, but hopefully you'll be able to follow along. I know there's a cultural affirmative language that needs to go through, and I'm not sure what that means. Sorry, Sonny. Sorry, cultural. Some culturally correct language that needs to go through that I'd like to add to the bill. And there are groups of people who have hearing loss, and there are people who are deaf and hard of hearing who have their own cultural group. And I know it's a little bit hard for some people in the majority culture to understand, but coming from the culturally deaf group, I'd like to explain some of the differences. I am super glad to see this provision of captioning mentioned in the bill, but it says DHHSD, and I'd like to encourage captioning for all of the state agencies. Brian and I have spent many conversations talking about captioning. We went to the University State Mankato and looked at the captioning there. That was great when I was a student there. It wasn't always accurate, though. I know sometimes if any of you have watched caption on TV, you see that there's sometimes errors made. And so sometimes I wasn't able to do my homework because I wasn't really getting the correct information from the class. So there are 22 states that currently have adopted or use PPR, which is the Registry of Report, no, I'm sorry. It's the National Court Reporters? National Court Reporters Association, the NCRA. They are required to do verbatim transcription on captioning. And I have to be honest with you, it's a little bit hard for me to judge what they're doing, but I think it's very easy deaf people are very easily exploited in the captioning realm because we can't tell if the captioning is accurate or not. And we can't always tell, we can tell if it's good English or not, but we can't always tell if it's accurate of what they're captioning. So I'd like to recommend some stricter standards for the qualifications of captioners. And I also see that there have been some things omitted from the bill, and I'm not sure why that is. There are some deletions that have been made from the bill, and I think they should be put back in. Maybe things there that were meant to clarify, I think it would be helpful for them to remain as clarifying points. The Deaf Resource Center for the Deaf in the Department of Education. The Resource Center for the Deaf was stricken out, and I'm not sure why that was. I'm not sure if it was just the Department of Ed was used instead, but I think it would be better to clarify the Deaf Resource Center, because there are great specialists there that really know deaf education. They have their the person that works there is Mary Cashman-Bakken, and she has not only her master's degree in deaf education, but as well a law degree. And I think we really need to specifically point out that department and that person. So I would object to this having stricken that specific department. And I think saying Department of Ed is a little bit too vague in that case. Also, there's a newly created title within the Department of Employment and Economic Development, DEED. The state has that, many states have that, ours has, and we've gotten that title again. It's called the State Coordinator of Deaf, and that individual is Elise Knopf. She coordinates all the deaf vocational rehab services throughout the state. And I'd like that reinstated in this bill, to mention that partnership by name with deed. I think it's very important. I'd also like to add, on item 200, the superintendent of Minnesota State Academy for the Deaf. That's an individual who, now we have a deaf individual working for our state academy. That's great. He works with the Deaf Academy and the Blind Academy. They're just a mile apart down there in Faribault. And they're working very closely in collaboration. We'd like that spelled out. This may be minor, but it's kind of important. The Minnesota Department of Human Rights, I think it would be nice if they are mentioned as a collaborator as well. The Minnesota Department of Human Rights has a reporting responsibility, and last that I've seen, now I guess don't quote me on this, I kind of just am a numbers junkie, so I like looking through these numbers, but the last I saw, they do reporting of the numbers of people who have filed complaints of discrimination in a variety of realms. And in looking at their numbers, the number of deaf people who have filed complaints is very low, astonishingly low. As a member of the community and the people that I've talked to in the community and the kinds of complaints that we have at the grassroots level, I'm surprised that so few of them get to the Minnesota Commission for Human Rights. Not as many as people from other disability groups file, it seems. So I'd like them named specifically so that we could partner with them more. I'd like to really emphasize overall collaboration in this bill. I'm concerned that some of the things have been taken out and some things aren't specified by name. I know you also added a definition of an interpreter. That's good. I'm happy to see that have been added. That's the kind of thing I'm talking about. But one thing that I think is missing, or I'm a little bit vague of whether it's really spelled out sufficiently or not in the bill. But one thing, as I've looked over the bill, I don't see is, as long as there have been deaf people, there has always been interpreters, and there's always been other deaf people. And I think that's something we need to, it's kind of a hot topic right now, because we've talked about certified interpreters as being qualified, and whether having certification actually is the qualification that they need to hold. But there is no certification for somebody who's a deaf-blind interpreter, who does tactile interpreting. I'm a third-generation deaf individual. My parents were deaf, my grandparents were deaf, and I use American Sign Language. And so I've been able to benefit from the use of competent interpreters, and I'd like to have that language kind of strengthened in the bill somewhere, if it doesn't really exist there. Then moving on to captioning. I'm not sure about the quality of captioning.
If I might interrupt. Mr. Wozlowski, I'm wondering if you have your testimony typed for the group, or?
I do.
We
I
are
have
running out of
copies.
time, and we do need to wrap up.
Yes, I have a couple copies, two other points I'd like to make if I could.
All right.
One is the quality of interpreting services. I know that our neighbors in South Dakota and Nebraska and Iowa and Illinois, all around us, all the other states have state licensure for interpreters. And I'm very disappointed that Minnesota does not yet develop something like that. I think there are poor interpreters out there, and I think a state licensure program would go a long way to alleviate that. So I wanted to throw that out there. And then my second point is, and I feel like this is important also, is that for the longest time, deaf and hard of hearing services, their role within schools and within the education of deaf children and families has been very limited. I see some interpreters there at the schools that shouldn't be there. I think recently we had a discussion about hearing loss and assisted living and the aging population, but I think we need to look at the other end of the spectrum as well. Isolation happens not only in old age, but it happens with our younger members as well throughout the state, who may only have the interpreter as their friend. They may not have other deaf people that live and work close to their schools. So what I support changing the language to be able to refer families to contact the state and have the state refer them to the Minnesota State Academy in Faribault. Right now, that's not happening. I think that's not on the table whenever they talk about options for families and educational options for children in greater Minnesota. And I think state agencies need to support the state school. I think that's very important too. So I know we're running out of time. I have a couple of copies of my comments. I apologize in advance. I typed House File 744, while I know well it's 774. Thank you very much for your time, and I appreciate your patience with me going on. Thank you, audience, as well.
Thank you, Mr. Wozlowski. I believe we have Michelle Paulson.
Thank you.
To the committee, Ms. Paulson, please
Yeah.
introduce yourself.
Thank you for allowing me to testify again here today. My name is Michelle Paulson, and I am a parent of a deaf, hard of hearing son and daughter. I just want to, again, ask for your support for this bill to help increase funding for the Deaf Mentor Program. My family has benefited greatly from the Deaf Mentor Program, and we've talked a lot about isolation and early communication, and I think language deprivation is a huge and real thing that we deal with. I can only imagine the struggles my family wouldn't have had to go through if I would have had access to the Deaf Mentor Program sooner. The school districts very much lack deaf and hard of hearing services, and what they do offer is very specific to the student and not the family as a whole. Kids don't stop being deaf once they leave school. You know, they need support and services at home to continue that education. We had to wait a rather lengthy time. I want to say it was roughly a year. We had so many other things going on at that time, actually consulting with lawyers and, you know, fighting our school district for basic communication rights for our children, that I don't know the exact time, but we were on a waiting list for the Deaf Mentor Program. There's currently, I believe, 33 families on that waiting list. And so when you have a diagnosis of hearing loss from birth and you don't get, you know, family services till 2, almost 3 years old, that's a huge language gap. And just think of how much my kids, and I'm sure other kids, are delayed. And, you know, I'm very happy with services we get now. We moved from Hermantown to Faribault, Minnesota, so my children could attend the Minnesota State Academy for the Deaf. Wonderful services, wonderful community, and we have a wonderful Deaf Mentor Program, and I hope that we can utilize that more for other families in the state. So thank you again for your time.
Thank you for your testimony today. We do appreciate it. Is there anyone else in the audience who'd like to testify on behalf of this bill?
I would like to.
All right. Come on down.
I'm making my way down as quickly as possible. Sorry, guys, just gotta. I got it. I know. Voice over.
Welcome to the committee. Please introduce yourself for the record and proceed with your testimony. There's a microphone right in front of you there.
Hello, my name is Cassandra Xavier. I am a resident of Minneapolis, South Minneapolis area. I am deafblind myself, and I would like to add to what the previous person had said about the whole isolation and stuff. So I really think that I've been saying this to most of the legislators I've been meeting with today, that the best thing that could happen is for continued support of deaf, hard of hearing services and deafblind services, and to continue letting us go forward with our advances to no longer be in isolation, because, you know, hearing loss, deafness, and hard of hearing is a true sense of isolation, and it's not a good feeling. And I'm pretty sure a number of you in here can agree. We need more SSPs and interpreters in as many places as we can get them in, schools, hospitals, and all of these things, and, you know, different organizations, even if it's not for the deaf and the hard of hearing and deafblind. Because in the near future, there may definitely be more deafblind people, more hard of hearing, more deaf individuals And if these services were to be eradicated or decreased drastically, how are we going to be able to progress in our community? And on top of that, the unemployment rate within the deafblind community is that much more affected than any other group, such as the blind community. So I don't exactly have an exact number, but I can tell you that it's quite serious. So if we can continue getting help and support in those areas especially, we can eradicate isolation especially. I came here just to talk about getting rid of the isolation within the deaf and the deafblind community. So I hope not to have taken up too much time. Thank you very much.
Thank you very much for your testimony, Ms. Xavier. We appreciate you coming down to the Capitol today and testifying. Is there anyone else who'd like to testify on behalf of this bill? All right. Representative Loeffler.
Thank you, Mr. Chair. Just briefly, I'd like to get some feedback, and it can be offline, but I'm really glad to see the updating of our approach to this. I happen to have an aunt and uncle who were deaf and helped me understand a little bit more the barriers and the isolation as well as the opportunities when you're able to find them. My uncle retired as a supervisor in a manufacturing plant, but I know his career had many challenges along the way. But one of the things I have always asked the Deaf and Hard of Hearing program at the state is to make sure that every person faced with these challenges has equal opportunity to support and the kind of services that they need and to get their issues addressed. And I see once again we are proposing to not change the regional office structure of DHS, but in DHHS to maintain 5 regions, one of which is the metro, which has over half of the population, disproportionately has a lot of Asian people who, because of their involvement with our wars in the past, because of the ordinance and other things they were exposed to and helping us with the war or being victims of the war, have a disproportionate amount of hearing loss within their community. And it isn't about the number of offices, it's about the opportunity to get your calls returned, to have equal time on the waiting list, to have equal opportunity to have your needs met. And I would like to hear a little bit more about how we could address that in this legislation as it goes forward. And like I said, I'd be glad to work with the advocates of this offline because I know we're short on time.
Thank you, Representative Loeffler. House File 774 as amended is laid over for possible inclusion in the Health Care Omnibus Bill. Representative Pearson moves House File 1490 be laid over for possible inclusion in the Health Care Omnibus Bill. Representative Pearson, we have the bill before us. I understand you have some testifiers.
We do.
Please bring them forward, and we'll do those first.
They're on their way, and before they sit down, I'll just say that we've heard this in Health and Human Services policy. This is treatments for permanent teeth now in this age group, which is something that will have longer-term consequences, and then there's a grant program that we have proposed here as well. And to give testimony, we have Dr. Peterson.
Thanks for coming back, Dr. Peterson. We do appreciate it. Unfortunately, I have to apologize in advance. We only have just a couple of minutes. We have capital investment coming in this room directly after us. We are out of time, but I do want to get this bill completed. So if you would please introduce yourself and proceed with your testimony.
Thank you, Mr. Chair and members. Thank you very kindly, also Representative Nils Pearson. My name is Vachuri Peterson. I'm a CEO of Community Dental Care. On page 1 of your handout, you will see the summary that the report of the bill you passed 2 years ago, and we have been making progress. Yeah, thank you. The handout is being passed around. So since August 2015 to present, 24 organizations supporting this initiative met 7 times, and to give advice and direction with the guidance of the MDH and Community Dental Care, who are the steering committee. Steering committee also met several times, and in May 2016, Community Dental Care started a pilot project for children aged 0 to 2. Then we also have hired, the MDH had hired a coordinator for this project, come up with the name of Healthy Teeth, Healthy Baby, based on a focus group finding. MDH designed and drafted oral health key messages for infants and toddlers in Somalia, Hmong, Spanish, and English languages for radio distribution to target communities. These radio stations serve more than 100,000 diverse groups such as Somali and other Eastern African communities on a daily basis. And you can see that the advisory group down there. On page 2, is a request for you to support HF 1490. First, we would like to ask the legislators to support prevention of caries in permanent teeth via school-based sealant program for children aged 6 to 10 years old, to 9 years old, I apologize. Studies have shown that without sealant, 40% of back teeth develop decay over 2 years process. With sealant, these reduced to 6%, and Fatima and will testify about this later. Secondly, we would like to ask legislators for your support in adding a clinical component to the existing state program you passed 2 years ago. This is necessary because early childhood caries affect the general population. However, it is 32 times more likely to occur in infants who are low in socioeconomic status, who consume a diet high in sugar, and whose mother have low education level. To help solve this problem and to respond to the bill you passed, we started a program in May 2016 called the 0 to 2 Minnesota Cavity Free Kids Program. This pilot program has seen 68 children thus far. Currently, we teach parents in group setting to care for their children's teeth. We provide lab-to-lab exam, prophy, apply fluoride varnish. From these, we learn many lessons, and that had helped us successfully implement our program, such as parents need to be taught more than once. A mother in a program informs us that she brushes her child's teeth rigorously, but her child still develops cavities. Upon investigating, we learned that the father continues to give the child candies and pops. This is important that we educate the whole family to be successful. We started our first cohort with 4 families, and now we have grown to have 16 families.
Excuse me, Representative Zerwas has a question? Oh, I'm sorry.
No, he's making fun of me because I moved.
Okay, sorry.
Candy and pop.
Okay. So now we grow to have 11 cohorts, and the program is really rolling with momentum. In some children, we found that excuse me, early cavity lesion after the parents brush the cavities, they actually reverse themselves, and so this is self-healing. On the handout in page 3, you have I have included a study done in North Carolina that explains the early prevention is effective in cost saving in the state and have positive effect to children. Nurtured properly, this program can really escalate rapidly through words of mouth from underserved parents and interpreters. The expansion of this kind of pilot program to many communities is necessary, so we can obtain more data at various communities to help us implement the work throughout Minnesota. This pilot program needs your support, and now I would like to invite Fatima, Ellie, and Pioneer to testify. Thank you so much.
I'm sorry, we are actually going to have to vacate the room in about 4 minutes because of capital investment.
Consider it done.
So you're going to be picking up the folders, Representative Pearson.
Happy to.
All right. Welcome to the committee. Please introduce yourself for the record. Thank you.
Thank you, Mr. Chair and members. My name is Fatima, and I work at Community Dental Care as one of the licensed dental assistant working with the Sealant program. And I can tell you that this program is very valuable to the students that we serve. We do provide dental health education, and we also provide sealants right at their school. And we also do dental screening, so if they have cavities, we're able to refer them and let their parents know. So this is really very important, and this funding will not only help us, it will also help other community dental clinics that do provide sealants for children. I would like to say thank you, and please support this bill.
Thank you for your testimony, and thank you for coming in today. We do appreciate it. Welcome to the committee.
Hi, I'm Pania Herr. Mr. Chair and community members, thank you for allowing me to represent our youngest community members today. I just want to emphasize that early childhood caries is the most common disease in children, 5 times more common than asthma. And without the program, Minnesota Cavity-Free Kids, we cannot tackle this. So I am asking for your support and for additional funding for this program. It works, and we look forward to helping more families. Again, there are 68,000 children born every year, and these are the families and the patients that we need to serve. So thank you so much.
Thank you for your testimony, Ms. Herr. We really do appreciate it. Is there anyone else in the audience who'd like to testify on behalf of House File 1490? Seeing none, any final comments, Representative Pearson?
It was less than 4 minutes. Thank you, Mr. Chair.
All right, thank you, Representative Pearson. We appreciate that. House File 1490 is laid over for possible inclusion in the Health and Human Services Omnibus Bill. And with that, the meeting is adjourned. Thank you.